So I'm a nurse. I'm an advanced nurse practitioner who specialises in haematology obstetrics, and then Laura is our maternal medicine nurse from Liverpool Women's, and Liz, haematology specialist midwife from Manchester. So we've worked together because we've set up a nurse and midwifery-led haematology clinic at Liverpool. So we've worked together to develop this clinical model of care. So we're just going to talk about it today. Yeah, so the clinic itself, as I said, it's run at Liverpool at the minute only, and it's a nurse and midwifery-led joint clinic. It runs every other week. We see 6 patients per clinic, and there's 30-minute slots for each patient. And then as how it came about, so as we've already heard, blood clots are the leading cause of maternal death. So we were finding that there was no clear pathway. I won't go into it too much because I don't want to rain on Liz's parade for later. But so yeah, there was no clear pathway, and we were getting lots of these women referred, and they actually weren't getting started on low molecular weight heparin. So they were waiting for the haematology appointment. They come to us. They might be 15 and 16 weeks by the time we actually seen them because of the clinical pressures. And we found that in the clinic, it was a lot of things that I could do with the help of Laura, that they didn't actually need to see an obstetrician, but just because they needed that extra thing, they were being referred in. So because that was all increasing the waiting times, the need for the clinic became. So me and Laura worked together and set up this clinic so we can now see the patients early on. We can get the heparin started, and hopefully we'll reducing that risk for them. Oh yeah, and it was sort of continuity of care as well for women. So a lot of these women I know from previous pregnancies, or I know them because they've got a haematological condition outside of pregnancy that I look after on our royal site. So it was a lot of continuity for them because they'd know me already. I'd see them at maybe the royal first, refer them over, see them again, and then I also do a postnatal clinic on our royal site as well. So they get to see the same person all the way through, which is helping with compliance, and it also reduced their appointment times as well. And it was optimal use as well of the medic slot. So we obviously have a joint clinic run with the consultant obstetricians and the consultant haematologist from the Liverpool hospitals. And obviously there was a lot of things that were booked in them slots that maybe in those categories that you've seen before, they may be in the A category that they didn't necessarily need to see. Me and Laura were more than capable, but it was all getting booked up. So now there's a better setup in their clinic also because of it. So this is just a little bit of the inclusion criteria of what we see in the clinic. So all the referrals at Liverpool Women's Hospital come through myself. So once the midwife at booking or whoever it is that sees them makes a haematology referral, they come through to me anyway, so I can triage them into whatever clinic they need to go, and I know if it's out of mine and Laura's scope of practice. So any ladies that have had a previous uncomplicated DVT or PE, we're happy to see them. Recurrent DVT and PE as well if they're anticoagulated outside of pregnancy, so they might be just on thromboprophylaxis outside of pregnancy. We're happy to switch them over and review them in clinic and make a plan for their care. Mild ITP is not required in any treatment in pregnancy, so usually I'll monitor them on the royal site, the platelet count all the way through, and then me and Laura will see them, discuss what that means for them, and make a little plan for delivery and put it on the obstetric notes. Gestational thrombocytopenia, so we'll see them there as well, counsel them on what that means. Once the low platelet count's being picked up, we can do all the investigations to rule out that it's not an ITP diagnosis, explain it all to them, and then we'll make a plan for the care as well throughout the pregnancy. Haemophilia carriers with an established diagnosis, so these are not women that are just turning up saying, oh, I think I'm a haemophilia carrier, or I've got a family history of haemophilia. These are women that have got a diagnosis. We know by genetics that they are haemophilia carriers. We know exactly what their family history is. We look at their own factor 8 or factor 9 levels, if they have normalised in pregnancy, and we know that they're carrying a baby girl, we'll be happy to see them in our clinic as well. If they're carrying a baby boy, they'll go to the consultant clinic. Type 1 VW, so von Willebrand's disease that have corrected as well, happy to see them. Autoimmune hemolytic anemias, not required in any treatment. We'll see them in conjunction with fetal medicine. Fetal medicine will keep an eye on the baby, and we're happy to look after the mum. alpha thalassemia carriers. So if they're symptomatic of anemia or the HB drops below 80, we're happy to see them as well. Same with the beta thals. Single positive antiphospholipid syndrome with an uncomplicated history. So if someone's had, arterial events or anything like that, then they would definitely be going to see the consultant. But an uncomplicated history, would be happy to review them. Hereditary spherocytosis, not requiring treatment. So if we're just monitoring their full blood count, we're happy to see them put a little plan in, talk about jaundice and things like that, what may happen with baby. Thrombophilia, so they're your ladies that are more high risk of developing VTE, so factor V Leiden, prothrombin gene mutation, protein S and protein C deficiency. The antithrombins would also always go and see the consultant. We'd be happy to see them talk about thromboprophylaxis and things. And a simple VTE in the current pregnancy, so if it was like a car vein clot or something like that, we'd be happy to see them as well. Ladies that we wouldn't see, so these are mostly, for, as you've seen on the categories before, the category C, so anyone with a hemoglobinopathy, a complex or a rare bleeding disorder, or ladies that haven't got an established diagnosis of a bleeding disorder. They will. Patients with a hemato-oncology diagnosis, they will need to see the consultants. Where we need to do any sort of counselling with a non-established diagnosis, they'll be seen. Complex VTE in the current pregnancy, anyone with TTP obviously will be seeing the most senior consultant. ITPs on treatment, hemolytic anemias on treatment, anyone with triple positive antiphospholipid syndrome, even if they've not had an event or they've not had an arterial event, they will need to see the consultants. Complex antiphospholipids, as I've said already, antithrombins, I've said already. Anyone with a previous diagnosis of a hematological malignancy, so even if someone's had, I don't know, Hodgkin's lymphoma in the past, they've been in remission for a long time, we would still get them to see the consultant. And anyone with a new diagnosis of hereditary spherocytosis or a hereditary spherocytosis that requires treatment. But this is going to run out of battery.
Yeah, I think so. Yeah, so as Francesca said, me and Francesca do this clinic jointly. So Francesca will review them from a haematology side, and then I'll review them from like an obstetric side. So I review the past medical history and obstetric history. I usually prep the clinic the night before just to make sure I've gone through all the notes and I know who the ladies are that are coming. So I ensure all the risk assessments are up to date and accurate. Sometimes these risk assessments are done at booking from sometimes junior midwives who mightn't fully understand part of the conditions. So I'll go through them all and make sure that all the risk assessments are up to date and act on any of the risk assessments where they're scoring for me. I ensure the patient is aware of all the planned maternity care. So sometimes ladies turn up and they're not sure why they've come to what appointments, so I make sure that they're fully aware, like who they see, and that they'll carry on the routine antenatal care with the local community midwife, but they're just coming to see us in a joint specialist clinic. And I make sure that they're aware of all the scans, what they've got planned while they're having the scans, any hospital appointments or glucose tolerance tests or things like that, what they've got coming up. I just make sure that they're aware of everything. I make sure that they're in Liverpool. We're a standalone unit, so we're a standalone maternity unit, and we work very closely with our loved colleagues. But I make sure that they're aware where to attend and when. So if they've got an obstetric problem with themselves, any abdo pain, PV bleed, and any problem with the baby at all, they come to us. If there's a problem with any chest pain, symptoms of the VTA, DVT, PA, they present at the LUF site. It's probably better. And I make sure that they're aware of all the contact numbers as well. So I have brief discussions into the plan, place and timing of birth. Is there any of them ladies in them categories as suitable to deliver on the midwifery-led unit, or which ones need to deliver on the high risk labour ward? And I go through talk through induction labour versus spontaneous labour. So some ladies might prefer to time their injections more accurately and come in and have a planned induction. Other ladies are happy would prefer a spontaneous labour, so we'll talk through that. And if elective caesarean section is indicated, I complete the consent form and I'm able to book that for them. And then for more complex discussions, I'll either refer to the obstetric team, so either that'll be the obstetric haematology team or a general obstetrician, or we've got a really nice consultant midwife for more in-depth choice of birth discussions as well.
So the slides I've got are just some examples of disorder-specific management steps. So we've developed this clinical model of care with the hope that it's something that can be shared across other units and adapted for your own uses. So these are just some examples that I've got up of what we do. So as Claire showed us with the different categories and different levels, you'll be dealing with different levels of things at your unit, so you can adapt the model hopefully to fit. But this is just examples of what we'd actually do in the clinic at midwives. It's already set up in Liverpool as a formal clinic, and we at St Mary's manage things slightly differently. We haven't got a formal midwifery-led clinic, but we've had haematology specialist role for over 20 years now, so there's an established pathway for seeing women with haematology issues initially by a midwife. So women with previous uncomplicated DVT and PE would review the history and diagnostic criteria at the time to confirm the diagnosis. There are so many women that we get referrals here at St Mary's that we see all the referrals, women that think they've got had a PE or a DVT, and when you actually dig deep into the diagnosis and what's happened with them, they haven't. So women will say, oh, I had a DVT after my section, they sent me home on injections. I had a thrombosis. You didn't have a thrombosis, you just had correct prophylaxis. You only had your treatment for a week or 6 weeks. So actually giving them the good news that they don't need to have injections every day through the pregnancy is really nice for them. But that's one of the important parts, and just giving them that confirmation of their health status, reviewing the family history, the treatment history following diagnosis is part of that. And we assess the appropriate prophylaxis management in line with current guidelines that you'd have at your local unit, and use whatever low molecular weight heparin is appropriate. And we schedule appointments to initiate treatments. So we're the first professionals women are seeing, and we start them on the treatment, make sure they're happy with what they're doing, and aim for within 5 working days of referral. But the length of time that goes before that referral is always the bit that changes. So mild ITP not requiring any treatment. Again, an example of what we do, see 2 to 4 weekly, depending on the gestation and the platelet count. If platelets remain above 80, there's no need for any treatment. If they fall below 80, they'd be scheduled an appointment for the doctor's obstetric haematology clinic. Continue monitoring in midwife clinic if appropriate, and complete a care plan by 32 weeks. And provide the ongoing midwifery care, and make sure these women most of all get their normal midwifery, make sure they've got their birth plan discussed, they've had all their normal needs, all the midwifery needs met, and just making sure that they're aware they need to attend the hospital clinic if the platelets fall to a level that requires more intense monitoring and medication. And postnatally within 6 weeks of delivery, and refer back to routine haematology for ongoing review and support. So the haemophilia A carriers with established diagnosis, again, this is what we do similar, with sort of reiterating what Fran said there. And fetal sexing bloods needing to be taken and sent to Birmingham can be done from 9 weeks. And as Claire mentioned earlier, the geographical area that we cover as a network is vast, and a lot of women don't want to come to St Mary's to have the bloods done. So I know we've worked from St Mary's with other areas to try and get women to be able to have the fetal sexing done locally. The blood gets sent off to the same place. So if the women have actually had the diagnosis and workup anyway, there's no reason why they couldn't have perhaps fetal sexing blood sent off as an early point, and it saves them at least one trip if they're going to have to make a trip. And then just type 1 von Willebrand's, very straightforward. We'd see them if they've got an established diagnosis. Aim to see them at 20 weeks for a VW screen. If bloods are normalised, see at 28 weeks or around that stage to complete a care plan. And these women can have normal midwifery care. We don't need to over-medicalise them. They can have the continuity with the community midwife, and get a better experience for them, I think, than having to traipse backwards and forwards to hospitals unnecessarily. There was something I was going to say there and it's just escaped my mind. No, it's gone. I'm sure it'll come back at an inappropriate moment. Yeah. So where are we next? Yeah. Any questions? Anybody? I'll come back out of the way so the other girls can get in. Anybody got any questions around that? Anything you want to ask? We can certainly send the model once it's approved and we've got it absolutely completed. We can send a clinical model of care out if anybody wants to have a look at that and use. You can then adapt what's in there for your own units, show the obstetricians that you work with and the haematologists what sort of standards we're working with, and have a guide for you guys to pick out maybe some of those areas that you can actually see the women with that have had a previous uncomplicated VTE, so they don't need to overload doctors. And hopefully once there are midwives and there are more midwives with direct access, it's going to be part of what improves the picture around thromboprophylaxis.